Welcome, everyone. Thank you for joining us today. My name is Lissa Martinez-Hubner, and I'm the Senior Event Coordinator at the Masonic Cancer Center. I want to welcome you to the Rural Health and Cancer Symposium today. All of our attendees are muted and video is disabled, but throughout today's presentations, we invite you to submit your questions for presenters through the Q&A function. You may use the chat function to send us any general or technical questions, and when you use the chat, you may want to adjust the to line to either all panelists and attendees or just all panelists. We won't be using the hand raise function today. I am pleased to introduce Dr. Karen Coons, who is the co-leader of the Screening, Prevention, Etiology, and Cancer Survivorship, or SPECS program at the Masonic Cancer Center. So Karen, I'll let you take it away.
Thank you, Lissa. Good afternoon and welcome. I hope everyone is doing well in these difficult times, and we thank you for being flexible with the last-minute rescheduling. I want to first recognize Lissa for all of her work in organizing this symposium, as well as the support of Kira Ellis from Community Outreach Engagement at the Masonic Cancer Center. This symposium was organized by the Screening, Prevention, Etiology, and Survivorship, or SPECS program. I'm one of the co-leaders of that program and will be moderating today. Our panel will describe several activities going on at the University of Minnesota in the area of rural health and cancer. We hope that this symposium will foster collaborative research activities among our members within the university and beyond. We will be recording today's symposium and will be posting it online in the next few days. All registrants will receive a link to access and share the presentations. Due to limited time, we can only take 1 or 2 questions per speaker submitted through the Q&A feature. For questions not addressed today, we will follow up with speakers at a later time, and answers will be also shared with registrants. We'll take a short break about halfway through the presentations. Our first speaker is Dr. Jen Pointer, who is the Associate Director of Community Outreach Engagement at the Masonic Cancer Center.
Hi, everyone. Thanks for joining us today. I'm going to be spending the next few minutes giving you an overview of our catchment area in terms of the population and also some cancer statistics. Next slide, please. Next slide. So before I get started sharing some data with you, I thought I'd just explain what our catchment area is so that we're all on the same page, and also why this is so important. So each cancer center is allowed to designate the catchment area, and this is meant to be a geographic area that is served by the cancer center's research, outreach, and treatment. And our catchment area for the Masonic Cancer Center is designed as the state of Minnesota. This is really important for our community outreach and engagement, as the National Cancer Institute has been putting new emphasis on making sure that we serve our catchment area. And this is through several new guidelines. One is that we need to consider the needs of our catchment area in our research across all of our programs, including both basic science and population research, as well as treatment and outreach. We also have a goal to obtain input from community members to help us better serve our catchment area, to make sure we're covering areas that they're interested in and addressing their concerns. And finally, our overall goal is to make sure our cancer control efforts reduce the burden of cancer in our catchment area. Next slide, please. I also thought I'd spend just a minute talking about how we define rural populations, since we'll be spending the next 2 hours talking about health and cancer in rural populations. So unfortunately, there isn't one defined way of characterizing rural populations. There are many different elements that are used. I've listed a few of the more common ones here. The rural urban commuting area codes, or RUCA codes. These are defined at the census tract level, which is a smaller geographic area than counties, and take into account the size of the population as well as commuting patterns into other areas. Another commonly used code is the rural urban continuing codes, or RUC. These are based at the county level and are based on population size as well as adjacency to a metropolitan area. And then finally, the metropolitan and micropolitan statistical areas are what is commonly used by the US Census Bureau in order to provide uniform definitions for statistics across centers. And one of the reasons that this is so important to think about is that the definition of rural is not the same across all of these constructs, and the data that we have does not always use the same construct. So it's just something to keep in mind when we're talking about different data. So for example, today I'm first going to give you some definitions of the Minnesota population from the State Demographer's Office. These data are defined by RUCA codes, and then I'll be going through some cancer statistic data from the Cancer Registry, and these are defined by RUC codes. So it's not exactly the same definition for all of the data. Next slide, please. So within the state of Minnesota, we have a relatively large rural population. Overall, 27% of Minnesotans live in non-metro areas, including about 8% that live in isolated rural areas. This is a slightly larger rural population than a lot of states within the US. And there are several characteristics that set rural Minnesotans apart from those who live in more metropolitan areas. And several of these are very important when we're thinking about cancer. So the rural population is likely to be older, with rural individuals more than twice as likely to be over age 80 years. And this is really important when we think about cancer because age is the largest risk factor for developing cancer. Rural Minnesotans on average also have lower incomes than their metropolitan counterparts. They also must travel farther to receive health care and are more likely to have public health insurance, which are important things to take into account when we consider health disparities. And finally, we see racial and ethnic distribution differences when we compare the rural versus urban population. So in the figure on the right side of the slide, I've included information from the Minnesota State Demography Center, characterizing by RUCA codes into the 4 main categories of metropolitan, large town, small town, and rural. And we see different distributions by race and ethnicity within these areas, with a larger percentage of the metro population being of non-white race and ethnicity, and smaller non-white populations within all of the other groups. And the one exception to this would be the American Indian and Alaska Native population, which has a larger percentage living in small towns and rural areas. Next slide, please. So for the next few slides, I'm going to show you some cancer data for Minnesota by geography, including both incidence data and also some mortality data. These data were all obtained from the Minnesota Cancer Reporting System, which is our state cancer registry, and represent data from the last 10 years. So on this slide, I'm showing you cancer incidence across all sites for males on the left panel and females on the right panel. These are stratified into metropolitan and non-metropolitan based on RUC codes, with metro in orange and non-metro in red. And then on all of the slides, I've indicated incidence rates that are different with a star. So you can see that when we compare cancer incidence by all sites across males in Minnesota, the only difference we see is that Black males living in non-metropolitan areas have lower rates of cancer. And for females, we see some small differences, with non-Hispanic white women having lower rates in non-metro areas, and American Indian and Alaska Native women having slightly higher rates in non-metropolitan areas. Next slide, please. So on this slide, I'm showing you incidence rates, not overall, but for specific types of cancer. So these cancers represent the 10 most common types of cancers in males and females. You'll notice that they're not the same for males and females. There are some slight differences. And again, showing the metro population in orange and non-metropolitan in red. And here we see that while we didn't really see a lot of differences overall in males, we do see some differences when we look at specific cancers, with a number of groups having higher incidence rates in the non-metropolitan areas, specifically for lung, colorectal, and kidney cancers. And then when we look at females, we also see some very small differences in incidence rates, again with higher rates in non-metropolitan areas for colorectal cancer and kidney cancer. And I wanted to drill down a little bit more on colorectal cancer, as this has been a very persistent difference that's been tracked by the Cancer Registry over the last several decades. Whereas we've seen rates decline in both the rural and non-rural population, we've persistently seen higher incidence rates in the rural population. Next slide, please. So this slide is just showing colorectal cancer incidence stratified by sex, also by geographic location, and also by race and ethnicity. So here we see that we have higher incidence rates in the non-metro areas for non-Hispanic whites for both males and females. But we also see some health disparities by race and ethnicity, where we have a much higher incidence rate in American Indian and Alaskan Native populations, both in metropolitan and non-metropolitan areas. And this really suggests that we may want to focus on why we're seeing these differences and perhaps increase our screening outreach to try to reduce these incidence rates. Next slide, please. So this slide is showing you similar data for cancer mortality by geography. Again, showing the 10 most common cancers in males and in females, looking at the mortality rates per 100,000 population. Again, with metro in orange and non-metro in the red bars. We see for males, we see some disparities or differences for the 3 most common cancers with higher mortality rates for colorectal, prostate, and lung cancer. And again, we see a difference for kidney cancer. And for females, we see differences for lung cancer in the opposite direction, and also for colorectal and kidney cancer. Next slide, please. So all of the data I've shown you so far has focused on the more common cancers. I also wanted to highlight a few notable differences for rare cancers. On the left, we're looking at cervical cancer incidence rates in women, and we do see some disparities by race and ethnicity, and also perhaps some higher rates in the non-metropolitan areas. This again is a screening preventable cancer, which suggests we may want to increase our outreach efforts related to this. And then finally, on the right side of the panel, I'm showing you the rates for mesothelioma by geographic region within Minnesota. And we see an increased rate of mesothelioma in northeast Minnesota, as shaded by the dark red bar in the upper panel of the figure. Next slide, please. So this was a really quick overview just to give you an idea of some of the demographic and economic differences that we see within our catchment area of the state of Minnesota. We do see some differences in both cancer incidence and mortality, particularly when we're looking at rates for specific cancers. And these suggest some areas where we may want to focus some of our research and outreach efforts to try to reduce these differences. And finally, I'd just like to highlight that these data are really helpful for describing the problem, but we'll really need more focused studies to try to understand why we're observing these differences. And finally, this has been a really quick overview. If there are particular cancers that you're interested in that I didn't cover, or you have specific questions, please reach out. I'm more than happy to talk more about some of these data. Thank you.
All right. Am I back on? Thank you, Jen. So there's no questions coming in, but I have, I'll just ask about the screening participation data. You mentioned sort of especially for cervical cancer and colorectal cancer. Do we have good screening participation by some of these rural, urban differences?
Yeah, it's captured in the behavioral risk factor surveillance system, and they have shown some data for the US overall, looking at differences showing that at least for colorectal cancer, screening rates are lower in rural areas. I wasn't able to pull out the data specifically for Minnesota. They don't have it set up that way, but I would guess that we can get access to those data.
So there's no Minnesota data per se, it's from the behavioral risk factor.
Yeah, so it does include Minnesota, but when they report data, it's only statewide for Minnesota.
Right. Yeah. All right, so we will move on, and we'll now hear from Dr. Deanne Lasovich, who is a professor in the Division of Epidemiology and Community Health in the School of Public Health.
Okay, thank you very much. I hope I have some data that shed some light on screening in urban and rural populations based on the survey that we did, so stay tuned. I'm going to present on a statewide survey of the Masonic Cancer Center catchment area, specifically focusing on urban-rural comparisons, given the topic of our seminar today. So next slide, please. I'd first like to give some acknowledgements. This study was funded by the National Cancer Institute as a supplement to the Masonic Cancer Center core grant. I'd like to acknowledge my co-investigators and collaborators, both within and outside the university. It was a team effort. I'd like to give a special shout out to Kira Ellis from the Office of Community Engagement and Education. She pointed us to focus on Greater Minnesota, and to Marie Rainey, who helped with developing some of the research related questions that we pursued. Next slide, please. So why do a survey of the Cancer Center catchment area? Dr. Pointer alluded to some of this in terms of knowing where the problems are, but she was focusing on incidence and mortality, and it doesn't say very much about the behaviors that we might have be able to change in order to better address these concerns. So cancer centers are expected to conduct ongoing assessments, as was mentioned, on the health needs of the populations they serve. And of course, the Cancer Center defines its catchment area as the entire state of Minnesota. The best survey on cancer risk factors, attitudes, communication, and information preferences is the NCI's HINTS survey. But as a national survey, the data may not be very relevant to a given cancer center's catchment area. And then while there are state-based surveys like BRFSS, they do not always include the level of detail on cancer to help cancer centers. So over the past 4 years, NCI has funded now 29 cancer centers to survey the populations of their respective catchment areas, and we were one of those grantees to do so. Next slide, please. We had 3 key specific aims. 1, to characterize the population in the catchment area of the Masonic Cancer Center by demographic and behavioral characteristics. We did this through a statewide mailed survey. And then we took it a step further with a plan to link each participant to a range of local, area, and community level data from multi-level analyses. And then our third aim was to collaborate with NCI HINTS staff and other participating cancer centers to merge and harmonize our data to work together in this effort. And we're already doing this with analyses that are currently underway across cancer centers with regard to urban-rural differences around the country in cancer beliefs and screening. And also we're doing an analysis of social determinants of health and cancer risk factors. Next slide, please. Okay, so I'd like to take a minute to describe the survey we did. It was a mailed survey conducted in May through August 2019. Households were sampled from a list that we purchased from SSI, now called Dynata. We mailed 1,600 surveys, 1,000 to 4 non-metro regions and 600 to metro area homes. We used the Dillman method to conduct the survey, initial mailing followed by a thank you postcard reminder with a second survey mailing later, and then one last reminder later. We included a $2 incentive with every survey mailing, and we had 722 returned for a 47% response rate, adjusted for the undeliverables. And this was similar whether the response was calculated for urban or rural areas. Next slide, please. So every cancer center survey was required to include a core set of demographic and behavioral questions that are on the HINTS survey. This would facilitate harmonization of regional and national data sets. On the right-hand side, you see that a survey by sheer coincidence was sent to our own Logan Spector on the day of a severe thunderstorm. So here it is, the survey and $2 bill drawing out. So you'll never know who's going to get your survey and also the conditions under which it's sent. Next slide, please. We listed a number of specific questions that we were interested in on overall health, other medical conditions, e-cigarettes, screening overdiagnosis. We had some specific questions related to research, because that's what the Cancer Center would like to do, is to provide research opportunities to the entire population of the state to better understand the issues that are related to cancer in those populations. So we asked about attitudes and concerns about research participation or giving biospecimens, preferred methods of recruitment, awareness of the Masonic Cancer Center, and also the statewide clinical trials network, which you'll hear about after my talk. Next slide, please. And this is the list of community level measures I mentioned. They came from the census, from the area health resource file, and from the Robert Wood Johnson Foundation County Health Rankings and Roadmaps. And at a later point, we hope to get actually area-specific cancer incidence and mortality rates. Next slide, please. So I'm here to talk about urban-rural differences observed in the catchment area survey, and we use the RUC definition of urban-rural codes. So those consist of 9 codes. Dr. Pointer already mentioned how they're defined, but RUC codes 1 to 3 is the urban population considered urban, and RUC codes 4 to 9 are considered rural. Now, you will note that when we applied these definitions to our sample, about 2/3 of the population were living in urbanized counties and 1/3 in rural counties. And our sampling strategy was just the opposite, about 2/3 from greater Minnesota and 1/3 from metro area. So you can see that this shows the number of Minnesota counties, even outside of the metro area, still meet this definition of urban. Next slide, please. Next slide, please. So for the table slide, I have a few here that I want to orient you. The second column always shows the urban data, and the third column, the rural responses. The last column provides a p-value for whether any differences are statistically significant. For those that are, I have highlighted them in a maroon outline. For other interesting findings, I've indicated with an arrow on the right-hand side. I want you to know these comparisons have not been adjusted for age or gender or other potential confounders, so they should be viewed as preliminary. So with regard to demographics, as shown in this slide, we actually find the expected pattern mentioned by Dr. Pointer. A higher proportion of Minnesotans living in rural areas were older than in urban areas. They tended to be more likely to have a lower income and less likely to have a college degree. Next slide, please. With regard to cancer risk factors and preventive practices like screening, we really didn't see any statistically significant differences. If you look at the percent current smokers, there does seem to be a greater proportion of rural respondents reporting being a current smoker than urban. And then, but not for screening, while there's some differences, they didn't reach the level of statistical significance. If you go all the way to the bottom line, I want to point out that whether one lives in urban or rural areas, the proportion reporting having undergone lung cancer screening among those who were eligible based on their smoking history and age, it was very low overall. So when you see those high incidence and mortality rates for lung cancer, this is an area obviously for improvement. Next slide, please. The proportion of urban and rural residents who reported having a cancer diagnosis did not differ. But with regard to awareness of the Masonic Cancer Center or the Minnesota Cancer Clinical Trials Network, the awareness was lower in rural populations compared to urban, but still the Clinical Trials Network is an area where the population as a whole still have a lot to learn about the opportunities that this group offers to them. And then the last line shows something that won't surprise anyone, and I think was also mentioned in Dr. Pointer's slide, that not only do individuals have to have further to go for their health care, but they're also rural populations more likely to report being willing to travel 50 or more miles for health care. Next slide, please. So engaging individuals in the research mission of the Masonic Cancer Center requires us to understand their concerns about participating in research. So we collected a number of items related to that. we found very high % agreement with no urban or rural differences regardless about who agreed about the benefits of research. So they tended to say, agree that health research improves future health care and services, that research offers enough safeguards to protect participants, that research can help prevent disease, and that research can help the participants themselves. So they all have very positive and similar attitudes about the benefits of health research. Next slide, please. There were also some urban-rural differences, and they really had to do with access largely. So urban respondents were much more likely to identify that research was available to them compared to rural respondents. And similarly, rural respondents were much more likely to report trouble getting to a study location as an important concern. Next slide, please. Finally, we asked about the effectiveness of various research methods for recruiting into research studies. So in the first row, by the arrow, hearing about a study from a healthcare provider was the most important source to encourage research participation. And that was similar for both urban and rural respondents. And then you see for other common methods that we use to reach individuals about research, letters from research studies, websites, study emails. Then in all those instances, individuals would be less likely to participate if that's how they heard about the study, if they lived in the rural region compared to the urban region. And then lastly, social media has become more popular as a way to try to recruit people. You see at the very bottom there that overall, a very small % of the population, regardless of where they lived, indicated that they would think about participating in a research study if they learned about it from social media. So that's something to keep in mind. Next slide, please. So the summary of our findings are these. Keeping in mind that the data are preliminary and the differences have not been adjusted, we can draw the following conclusions. Any demographic differences that we saw in our survey mirror those of Minnesota. We also found that most cancer risk and preventive factors were similar. The awareness of the Cancer Center was lower in rural than urban areas, but positive attitudes about the benefits of health research participation were similar and quite high. Concerns about health research that were more common among rural than urban respondents tended to focus on issues related to availability, access, and technology. Next slide, please. So NCI, I want everyone to know that NCI intends to support cancer centers to repeat these surveys over time. So this is just the beginning of creating a rich resource and profile of the cancer needs of Minnesotans to better serve the state. And these data are also available to all Cancer Center members for preliminary data for grant proposals or for papers that somebody might be interested in writing. We just need to have a proposal about what that might be. So I encourage you to see this as your resource and make good use of it. And as I said, it's just the beginning, I think, of periodic surveys of the state to better understand cancer risk factors. Thank you.
Great, thank you, Deanne. There are no questions coming in through the Q&A. I will acknowledge one that came in through the chat box about the Somalian population and sort of where they fit in. Nothing has been sort of specifically mentioned. And just to say that we will sort of get that obviously a very important population for the state of Minnesota, and we will sort of get an answer out with our in the future for that. And thank you for Deanne for mentioning the sort of ongoing opportunities potentially for sort of using this type of survey in the future, because I think that's going to be important to continue to sort of get a take on behaviors in our state.
Right, it will offer an opportunity to add new questions as we identify new risk factors or new concerns related to cancer in the state.
Absolutely. Okay, so next I'm pleased to introduce Cheryl Stibbe and Raina Lead from the Minnesota Cancer Clinical Trials Network.
Hi, I'm Cheryl Stibbe, and I am the project manager for the Minnesota Cancer Trials Network. And along with my co-worker, Raina Lead, we're going to give you just a little insight on what we do. Next slide, please. The Minnesota Cancer Clinical Trials Network aims to improve cancer outcomes for all Minnesotans through greater access to cancer clinical trials in prevention and treatment. We were funded by the state legislature through MinDrive in 2017, and we offer investigators the opportunity to enroll patients throughout Minnesota under cancer clinical trials that are brought forth through the Masonic Cancer Center at the university, the Mayo Clinic Cancer Center, and sometimes through the Hormel Institute. Next slide, please. This is a picture of our team, otherwise known as the Hub. Our medical director is Dr. Charles LaPrinzi, and Dr. LaPrinzi is located down at the Mayo Clinic. Our senior network manager is Marie Ronnie. Myself and Raina is our regulatory specialist. Jesse Elkhire is our communications and marketing coordinator, or also we've been calling it engagement, trying to engage our community. Brinsley Davis is our new program coordinator. And then Patty Beckman is an oncology patient access nurse through the Masonic Cancer Center, who also answers our 1-800 number for studies and does a lot of contact with the patients, answering questions about what trials might be available for them and other questions and support they may have. Next slide, please. So who are we? We are 3 institutions, 5 partners, and 19 clinics. And the previous slide was the Hub, and that's where the overall management of the network happens. And we, minus Dr. LaPrinzi down at Mayo, the rest of us are located here at the Masonic Cancer Center on the university campus. Our 3 research partners, or the institutions that where the studies are originating from, are the university, Mayo Clinic, and the Hormel Institute. And our 5 clinical partners, in essence, where all the action happens and where the studies are conducted, are Essentia Health, the Mayo Community Clinics, Sanford, Fairview, and MCORC, which is the Metro Minnesota Community Oncology Research Consortium, which is MCORC is much easier to say. And they do have some outside of the metro clinics. And also it's important to note that our clinical partners also do, besides only conducting and enrolling in MNCCTN studies, they also do NCI Community Oncology Research Program studies. Next slide, please. This is a depiction of where our clinics are located throughout the state at the present time. We do have 19 clinics open currently. And one of the things that was set forth when the network was opened is that all of the clinics needed to be outside of the 7-county metro area and outside of Olmsted County, where Mayo Clinic is located. So you can see here, we do have a pretty good coverage. We need a little bit more on that western side, but we're working on it. Overall, throughout greater Minnesota and through MNCCTN network, we have 415 Minnesotans enrolled in clinical trials. And that number includes some of those NCORE studies that our partners are working on through the community. We have specifically 143 enrolled just on MNCCTN trials. So those are trials that have come specifically out of our network and that we've been able to roll out to our partner sites. And on the right-hand side, you can see some of the trials that are happening, and that we do have currently about 6 to 8 trials in the pipeline as we're continuing to roll and develop things that we can bring out to our partner sites in greater Minnesota. Next slide, please. So what studies are we working on, and what could be a possibility if you're thinking about joining us? Next slide. So our studies encompass interventional, prevention, and observational studies at this point. Our very first study, we just completed enrollment the end of March, with our final patient, I think, is going through at the end of this week, and that's a trial with Dr. Anna Prisment, who will be following us talking. It was a pilot trial to examine the effect of ginger on the gut microbiome. And we did get really good engagement through the community and work through our partner sites. So it was very exciting for all of us to see our first one start and finish and successfully. We also do have one where we're looking at trying to understand the barriers to lung cancer screening for the Minnesota Native American Clinic. We are in the process of beginning to roll out our very first interventional drug study, exemestane, and this one is coming out of the university, Dr. Manish Patel at the Cancer Center. Another one very close to being opened is a cohort study of disulfiram in chemotherapy in pancreatic cancer patients. And that one is coming from our partner site, Mayo Clinic, Dr. Amina Jatoy. And then we do have two other ones that nasal vestibulitis, the natural history evaluation. Dr. LaPrinzi, our medical director, is the PI on that one. And then we kind of have the sister study, rose geranium sesame oil nasal spray, as kind of the next step in treating those nasal vestibulitis treatments. So we do kind of have a gamut, which has been really good for us in beginning to roll this out to our partner sites. Next slide, please. So if you're thinking about what kind of trials are we looking for, we're looking for investigator-initiated trials, either late phase 2 or phase 3. And in general, they should be interventional. And observational or pilot that's planned after that is fine, but we really would like to kind of keep moving in the interventional arena. And it's very important to remember that it can be anywhere in the spectrum of the cancer care, including prevention, screening, and survivorship. And most importantly, we have to address the cancer burden in Minnesota. It's easier for recruitment standpoint if we have studies that encompass some of the more commonly diagnosed cancers. And as we have seen on some of the previous slides, the breast cancer among women, prostate among men, and some of the other ones. I know we do have some melanoma studies, so there are things that commonly diagnosed are easier for us to enroll on. And also if they fit well within the standard of care for these patient populations. It's way easier to get people to comply and want to travel that extra distance if we can fit it in with what they're already doing for their regular care. Next slide, please. And the resources that we offer as a network to some of our partners and our investigators is increased enrollment and access to those rural communities through the relationships and the support systems that we have developed through our partner and community sites. We offer project management, regulatory support, and that engagement marketing piece. And we do a really important piece is through that money that has been given to us by the legislature is meant to support the infrastructure costs at the site. So that includes the staff costs, this paying for the coordinator, paying for the -80 freezer, the special centrifuge, those types of things. So the infrastructure costs for studies are covered for when you're running a study through the network. Next slide, please. And funding. If you're an investigator and thinking about, gosh, do I have a potential study for the network? Trials that are brought forth should be funded or have funds available. In the process of getting funding or waiting for funding, because we as a network don't necessarily fund studies, but we will help with the infrastructure piece with covering the staffing. And if you are applying for funding or kind of in the beginning of writing a grant, please reach out to us beforehand, because then we can help you with some budgeting ideas, and especially with the consideration of the single IRB costs when we're looking at multi-site trials. That's really important piece, because that can get really expensive if we need to go out and use a commercial IRB. We have been fortunate that we've been able to, we'll start to use the university to some degree, and Mayo Clinic has been a great partner in that. So we've been very fortunate. And then we are also able to help provide letters of support for those grant applications in helping to obtain that funding. Next slide, please. So what does working with MNCCTN look like? And Raina will take it from here. Thank you, Raina.
Thanks, Cheryl. So now that we have a pretty good idea of what MNCCTN looks like, we're going to talk just briefly about what it actually looks like to work with us. And we'll go into some more practical details. Next slide. Okay, so we're just going to go through sort of the process. You know, I think multi-site networks are sort of a black hole for a lot of people, and we wanted to talk about how it actually works in our network. So we do have a several-step process, which starts with the investigator submitting an application. This could be at the point at which a protocol is written, or during a grant application stage. We then do have a protocol and feasibility review, in which we make sure that the study fits well with our partners, as well as making sure that the science fit well with community clinics. And then there's planning for startup. I think we're all well aware of what happens during startup. The IRB submissions, making sure that we've got all our forms ready, all the signatures ready. And then we do actually go through startup and enrolling and greenlight all of our sites. Throughout all of this process, we have standing meetings with the study team, and we also conduct monthly meetings with our partner sites, several different calls, one with the operations, who are mainly managers, the coordinators, as well as regulatory. Those are all of our monthly calls. Okay, next slide. And I do want to point out the sort of responsibility split between the network and study teams, because this can become pretty confusing. Here at the network, we like to act as sort of the main point of contact and sort of funnel everything from the study team to the sites, and from the sites to the study team. There's often an immense amount of questions that come up during a multi-site study, and we want to make sure that we can take that burden of answering those questions off of a study team and busy clinician investigators. We also handle a lot of the contracting that's required with the sites, as well as the regulatory and project management aspects. We also write the manual of procedures, and then we have been blessed to be able to partner with the university's CTSI to conduct quality assurance monitoring. And then the study team, of course, is in charge of protocol development, FDA, clinicaltrials.gov, study drug, that sort of thing, which are pretty standard. Okay. Next slide. We do have shared responsibilities between the network as well as the study team. Those are the Reliance and IRB submissions, where we often have to work with the study team to make sure things get submitted to the right place in the right time with the right documents. We do coordinate training, as well as having site initiation tracked as well, where we track, let the study team know, they ask questions, we handle it with the site. And then we do have the shared responsibility of making sure that budgeting is right. Sometimes there are additional requirements with a multi-site study. For instance, shipping of either blood or tissue back is always sort of a new process for investigators not used to running multi-site studies. So we do have quite a few shared responsibilities. Okay, next slide. So now that we sort of understand, where we are at, what we have done so far, and how we're going in the future, I think it's important to also take some time to really talk about what we've learned in the several years since we've been open and running studies. So next slide. So really the big key that we've learned all really relates to how we interact both with the study team and with our sites, without which neither of these our network wouldn't be able to run. So really stressing collaboration, leaning on those existing resources at the university, leaning on those resources at Mayo, as well as leaning on the study teams to help refine protocols for community settings, and then talking with the partners to figure out what actually works for them. We don't want to make the network burdensome either to the study team or to the clinic sites. We're supposed to be there to make things easier for them. And then learning, continuing to look at our processes, figure out what doesn't work, what hasn't worked, what we can actually do to make it better, and then just communicating, making sure that we are in communication with both the study team and the partners at all steps, and really just making sure that everybody's aware of what's going on. So, we don't get that 5 p.m. Friday email and say, what's going on with that? We've already sent it out and we've had meetings about that. So really just making sure that we as the sort of middleman between the sites and between the study teams, we're really doing our best to facilitate communication as well as updates. Okay, next slide. So how do you actually get involved with MNCCTM? So next slide. So one of the most exciting things that we are proud to announce is that we will actually be putting out an RFA sometime in the fall. We're still working on final details and dates, but there will be 2 grants, both of which are at $75,000 with 2 years of funding. One will be internal to a Masonic Cancer Center member, and one will be external to UMN, which is specifically designed for investigators at our partner organizations. Where studies should be new ideas or proposals. We don't want to look at protocols that are, currently up and enrolling. These are for new studies that are specifically written for our network. We will have a formal announcement sometime in the fall. Some of these details may change as we confirm the process with everybody, but please, we want to stress to look forward to that, which will be coming in the fall. Okay, next slide. And so how do you actually get involved with us? At this point, the best way is actually to email. Normally you would email Marie Ronnie. She is out on maternity leave through August. So we were asking you to email Cheryl Stibbe, who's the project manager who we just heard from. She's your best point of contact. You can also email our medical director, Dr. LaPrinzi. And we are very happy to have more in-depth conversations with specific investigators who are interested in working with us or interested in hearing what we've done, as well as groups. You may have, research groups at your university or your organization that's looking to develop studies. We're happy to have conversations with them. And we want to stress that the earlier, the better. There are some nuances to developing a protocol for the network. There are some nuances with running a study through a network. And if we can help get in on the ground floor of writing those processes, that actually works the best. We're happy to have conversations about grant applications and budgets. The thing that I want to emphasize here is we're happy to talk to anybody about anything. Okay, and next slide. Okay, that's it.
Thank you. So I think in the interest of time, we will move on to hear from Dr. Anna Prismant, who is Associate Professor in the Division of Hematology, Oncology, and Transplantation.
Hello. Can you hear me? Yes. So my study has been already introduced. It's pilot trial to examine the effect of ginger on gut microbiome, and it was funded by Masonic Cancer Center and MCCTN. And thank you for the opportunity to talk about this study. It's the first time. As Cheryl said, we just finished it. So that's very exciting for all of us. Next slide, please. So there is a lot of experimental and epidemiological evidence that the use of ginger root is associated with decreased risk of colorectal cancer. And there are studies from Hormel Institute in animal models that clearly showed the beneficial effect of ginger. But the mechanism through which ginger exerts its effect is unclear. And so we hypothesize that it can exert its effect through impacting gut microbiome, because gut microbiome has been linked to inflammation, immune response, and colorectal cancer. So we hypothesize that use of ginger will be associated with decreased number of pro-inflammatory bacteria and pro-carcinogenic, and increased number of anti-inflammatory and anti-carcinogenic bacteria. Next slide, please. And so our specific aims were that we're assessing the effect of ginger on gut microbiome and systemic inflammation by examining the composition of gut microbiome and pre-specified bacteria associated with inflammation and colorectal cancer from previous study. Also, we aim to examine the correlation between ginger-related changes in microbiome and levels of systemic inflammation measured by prostaglandin E2. And our second aim was to evaluate the feasibility of conducting a randomized clinical trial using MNCCTN. Next slide, please. So this is design of our study. Our goal was to recruit 100 subjects who have colorectal adenoma, and they received ginger or placebo for 6 weeks, and then washout period for 6 weeks. And we were very lucky that the company Pure Encapsulation donated ginger extract capsules for us. The participants took 2,000 milligrams each day, and they were randomized either to ginger or placebo of the same size. And then stool and urine samples were collected each 6 weeks. And next slide, please. So you already saw this map with enrollment sites, and it's similar to ginger. So our main site, leading site, was University of Minnesota, but it was great that we were able to collaborate with MNCCTN so that we could recruit rural population. And you can see that there were many participants from Fairview, at University of Minnesota, other sites, and some people were recruited from Mayo and from Essentia. It's here. So if you look at the other diagram, we can see that University of Minnesota recruited 16 participants, and then we stopped at this point. It was our goal, and then other sites recruited the participants during like 1-2 years time frame. And yes, this was the first trial. So University of Minnesota started much earlier than everybody else. And then we stopped recruiting because we wanted to recruit from rural population. As a result, we recruited 69 participants, and then we stopped because of coronavirus. So we're a little bit short of our goals, but anyway, we're very excited that 64 participants will finish our study this week. Next slide, please. And this is enrollment at different sites. Overall enrollment on the left figure, and then enrollment by sites. And yeah, like we can see that it just, mainly the enrollment started like in the end of last year in all rural sites. So I think it went pretty well in general. So next slide, please. We just started analyzing a little bit of our data, and the age was very similar across sites. The mean age is in yellow. So it's interesting that in the University of Minnesota, so which is urban site, the age was a little bit older than on all other sites, and I cannot explain this. But the other distribution by sex is explainable quite well. As always, there were more women than men during the recruitment. So next slide, please. So the main conclusion is the collaboration between the ginger study team and MNCCTN worked very well. And due to this structure, we were able to recruit subjects from rural Minnesota that we wouldn't be able to do without this study. The other conclusion that we made that the MNCCTN provide great help, but having a study coordinator specific for each individual study would be necessary so that everything went smoothly, because this is the person who knows all the details. And so we are very grateful to our coordinator, Jen Stroberg, who has been working with both with sites and with MNCCTN. Next slide, please. Yes, and this is thank you for everybody who participated in this study, to coordinators, Jen and Allison that I already mentioned. And it was a great team, with multidisciplinary team, that which was successful. Thank you.
All right, I guess a question for, and again, we have no questions coming in, but I wonder how, and this may be for the Cheryl or Raina, how is COVID affecting the trials that are either undergoing or about to be launched?
It has affected us considerably on some, because some of our studies that we did have actively enrolling were open at the university, and because of the way the university is structured, we needed to stop. So some of our studies did absolutely stop, and we were dead in the water. Others, because some of our partners were in obviously different locations of the state, they were able to keep going because of the remote capabilities that they already have in place. So it was kind of a mixed bag.
Yeah. All right. So we're going to take a very quick break, 5 minutes, get up and run around, and we will convene at 2 p.m. All right, hopefully everyone's back and ready to move on to part 2. So we'll continue with our next speaker, Dr. Carrie Henning-Smith. Carrie is Associate Director of the Rural Health Research Center.
Thank you, Karen. I'm glad to be with all of you today to talk a little bit about the Rural Health Research Center here at the University of Minnesota, where I am the Deputy Director. The purpose of this is to give you a sense of some of the other related rural health work going on at the university, and to talk about places where there might be potential collaboration. I do want to put in the caveat that while we do a lot of rural health work, very policy relevant work that's certainly relevant for cancer and cancer research, we are not the only folks doing rural health work at the university. And so I encourage folks to seek out all of the potential collaborations across the university. There's a lot of really good work being done. Next slide, please. I think it's good practice to start all of my presentations with a land acknowledgement. I realize that we are not physically together on the same space right now, but it's important to acknowledge that the University of Minnesota Twin Cities is located on the ancestral home of the Dakota people. Next slide, please. So I want to talk about what the Rural Health Research Center is, who I work with, and how we work together. First, I want to acknowledge my colleagues. We are a small but mighty group. Katie Casamano is the director of the center. She and I work very closely together on all issues related to the center. And then we have 2 staff members, Megan Lauer and Mariana Tuttle, who do a lot of both research and administration oversight of the research center itself. And then we work with different faculty and staff across the university and students, depending on what the various research projects are. The Rural Health Research Center is supported by the Federal Office of Rural Health Policy, located within HRSA. And we have a cooperative agreement with the federal office, which means we tell them what projects we think need to be done and are important to be done. And then we get feedback from them about the projects that they are hearing from members of Congress or CMS or other branches in the federal government about questions that they want investigated. And we work back and forth together to decide on our topics for each given year. As such, our topics are informed by policymakers, rural health stakeholders, the literature, and an expert work group, which I'll talk about in just a few minutes. Next slide, please. Our mission in all that we do at the Rural Health Research Center is to conduct policy relevant research that's key. Everything that we do, we talk about policy implications for. And the goal of that research is to improve the lives of rural residents and families, to advance health equity, and to enhance the vitality of rural communities. I would argue that's very much what's being done by all of the other researchers who've already spoken on the call today too. Next slide, please. A little history about our center. We started in 1992 under the direction of Dr. Ira Moskovitz, who is a faculty member in the Division of Health Policy and Management. We've been continuously funded by the Federal Office of Rural Health Policy in HRSA. And the structure of our center and our grant is that we do 4 projects a year, 16 projects per grant cycle. We have 4-year grant cycles. Our work is national in scope, and again, it's policy relevant. We have a variety of focus areas, but generally we look at issues related to quality of care and access to care and social determinants of health across the lifespan. Again, issues that are incredibly relevant for cancer researchers. Within the Rural Health Research Center, beyond the main grant that I'm talking about here, we also have other rural-related grants and contracts. These include the Flex Monitoring Team, which I'll talk about again in a few minutes, some evaluation work that we do in collaboration with NORC out of the University of Chicago, and the development of rural health toolkits. I'll talk about that in a few minutes too. Next slide, please. We are not the only Federal Office of Rural Health Policy funded rural health research center. In fact, there are 7 across the country. This map shows the places in blue that have a currently funded center or centers in some cases. And the states shown in green have had one at one point in the past. Next slide, please. So these are our current Rural Health Research Center projects. We do our projects on a September 1st through August 31st timeline, which means that we are reaching the end of each of these projects. I don't have time to share a lot of results that we have from these today, but I would be more than happy to if someone wanted to reach out and had questions about any of these. But right now we are looking at community context and rural strategies to support the oldest old, folks who are 85 and older, emergency obstetrics in communities without hospital-based maternity care. This means that we're looking to see what happens when someone has a hospital and that hospital may have an emergency room, but does not have obstetric services. How does that hospital prepare to support individuals giving birth in those situations? Living alone, rural-urban differences and the prevalence, sociodemographic correlates, and health needs across the lifespan. And finally, making it work, models of success in rural maternity care. Next slide, please. So as I said, we do 4 projects a year, 4 years per grant cycle, which means that our brain spaces are in a lot of different places at any given time. And this is just a sense of the other projects that we've done recently. These are the past 2 years before the year that I just talked about. We've done work on access to care for Medicare beneficiaries. We've done a number of projects on obstetric care and maternity care quality and maternal morbidity. We've done work on team-based primary care. We've done work on health equity and disparities by race and ethnicity among rural residents. We've done work on COPD, on social isolation, on caring for unpaid and family caregivers, and on opioid-affected pregnancies and births. Next slide, please. As I mentioned earlier, we have an expert work group that guides and advises all of the work that we do. This is critically important. We can't do really good rural health research from the middle of Minneapolis or from our virtual spaces in this current moment without talking with people who are in touch with what's happening on the ground in rural areas across the country. And as such, we have a work group that guides us. We have 2-year terms for work group members, so people rotate on and off. This is the current composition of our work group, and it represents people from all over the country, individuals who are providers in rural communities, who work for advocacy groups, who do programming, and who do research. So we have a range of different expertise, but these are all people with lived experience in rural communities and grounded experience in what matters for rural health. Next slide, please. When we do our work, we put it out with a range of different types of products. We're academics, so of course we publish peer-reviewed manuscripts. That's important as the currency of our work. But it cannot be the end all and be all of what we do, because we are interested in impacting policy and in doing work that's meaningful for the public and for rural residents. We put a great emphasis on putting out products that are freely accessible and that are written for a lay audience. So in addition to peer-reviewed manuscripts in journals that sometimes live behind paywalls, we publish a lot of policy briefs. These are available for free on our website. You can see a couple of examples of what those look like on the slide here. We publish case studies where we highlight exemplar cases in different areas across the country. We are just finishing up a series of case studies on successful maternity care in rural areas that should be out in the next few months. We publish practical implications. This is where we take a challenging, complex rural health issue and get the feedback of practitioners and providers in rural communities to talk about the implications of that issue for their community and what it means to serve the patients that they serve. We are just starting to put out chart books. We are finalizing our first ever chart book now, and this will be on rural-urban differences among older adults across the country. And then we have just started wading into doing infographics too, with our first infographic looking at rural-urban differences in the prevalence of living alone across the country. Again, trying a variety of formats so that we can make sure that products are salient and accessible for a wide range of audiences. Next slide, please. As I said, you can find all of our products on our website. You can go to rhrc.umn.edu and click on our publications tab there. You can sort by topic, by keyword, by publication type, if you're interested in just some of the publication types that I mentioned there. We'd love to have people visit the website and are always happy to answer questions. Next slide, please. You can also find our research as well as the research of all of those other rural health research centers that I mentioned with the map earlier on the Rural Health Research Gateway. The Rural Health Research Gateway is run out of the University of North Dakota. It's funded by the Federal Office of Rural Health Policy, and it's meant to be a clearinghouse of rural health research that's funded by HRSA. It puts out alerts anytime there's new work from any of the research centers, so you can sign up for email alerts there. It doesn't otherwise spam you unless there's new research coming out. And there is certainly cancer relevant and cancer related research that comes out and is disseminated through the gateway. So if this is something you're interested in and you'd like to know what research centers are doing across the country that may or may not be related to cancer, I would encourage you to look on the gateway and to sign up for their email alerts. Next slide, please. In the work that we do, as I said, we really put an emphasis on ensuring that we have publicly available products that are easily accessible to the general public. We also do a lot of work promoting research projects among target audiences and key stakeholders, and we do what we can to maximize our reach and our impact within our budget constraints. As I said, we're small but mighty. And to do that, we build a dissemination plan into the structure of every project that we do. Next slide, please. We disseminate our findings not only through the types of products that I mentioned earlier, but through all of these other means too. We use social media, we publish quite a bit through op-eds, blog posts, letters, and commentaries, engagement with media of all sorts. We have been doing a lot of media engagement in the time of COVID recently. There are so many rural specific issues as they relate to COVID that we've been talking with local, national, and regional news outlets quite a bit. We do a number of webinars, not ones that we produce necessarily, but a lot of other opportunities to promote our research and share our research through other webinar venues. Same with podcasts. And we put out an annual report highlighting all of the work that we've done in any given year. You can find that on our website. Next slide, please. I mentioned public engagement earlier. I know this is a really important value of cancer researchers on the webinar today too, but I wanted to share some of the ways that we engage with the public to try and make that connection between our research findings and policy action. To do this, we do what academics do, and we present findings at state and national meetings, but we also engage quite a bit with policymakers, both state and federal. Just yesterday, I was on a call with Senator Smith's staff. I'm doing a roundtable with Representative Angie Craig in a couple of weeks. And that's kind of part and parcel with what we do, talking with policymakers about our findings and how they relate to policy issues that they're wrestling with right now. Do a lot of sharing findings with state agencies. We work closely with the Minnesota Department of Health, among others. As I said, we work closely with our expert work group. As much as possible, we spend time in community. Again, I don't think we can do rural health research well without spending time in community. We do a number of site visits, qualitative work that takes me and others into community. I'm not doing as much of this right now in the time of COVID, and I'm really missing it. And then we find that our focus areas are informed by all of this engagement that we do, but also by rural residents themselves and the policymakers, providers, and clinicians who serve them and care for them. Next slide, please. And I mentioned we do work outside of the Rural Health Research Center grant structure. Some of this is to develop toolkits that live on a website called the Rural Health Information Hub website. If you only take one thing away from my presentation today, let it be the Rural Health Information Hub. If you're not already familiar with this, it's a fantastic resource of all sorts of rural relevant information meant for a lay audience, certainly has cancer related information on it. Next slide, please. This is a smattering of some toolkits that I have developed in the past few years. These toolkits take a complex topic and provide very specific, pragmatic ideas for how these issues can be addressed within the constraints of rural communities. The toolkits I've developed most recently are on aging in place, mental health, and suicide prevention. You can find all of these for free on RHI Hub. Next slide, please. As I mentioned, we also are the home of the Flex monitoring team. This works with critical access hospital data across the country. These are the 1,300 or so small rural hospitals that are designated as critical access and serve a really vital need in rural communities. We are the administrative home of the Flex monitoring team, and we also do all of the data analysis around quality at critical access hospitals. If you're interested in any of that hospital-based data for critical access hospitals, this should be your first stop to find it. Next slide, please. And then we do other work under other grants not funded by HRSA. As some examples, recently I've done some work on farmer mental health funded by a grant from the USDA funneled through Michigan State. Just finished up a project on public transportation and social isolation funded by the Federal Transit Administration, funneled through the National Center for Mobility Management. And I just chaired a work group in New York State on rural suicide prevention. I've also collaborated, as Deanne said earlier, on some of the Cancer Center projects, which is really a joy. Next slide, please. And I want to thank you for your time today. I'm sharing my email address. If there are any of the projects that I mentioned that you're interested in, please don't hesitate to reach out. Thank you so much.
Thank you. Still no questions, so I will just move on to our next speaker, Dr. Colleen Longacre, who's a recent graduate in health services research.
All right, thank you, Karen. Good afternoon, everyone. Thank you for inviting me here today. I'm so excited to present some of my research entitled Travel and Treatment Among Breast Cancer Patients, a Population-Based Study. Next slide. Before I begin, I would like to acknowledge that this research received funding from an Agency for Healthcare Research and Quality R36 dissertation grant, and I'd also like to acknowledge my co-authors, Dr. Beth Bernig, Dr. Hannah Naprash, Dr. Nathan Shippey, and Dr. Todd Tuttle. Next slide. So we know that cancer patients living in rural areas experience worse outcomes compared to urban patients. As you can see from this figure, there's a persistent and widening gap in cancer mortality in rural counties. In 2015, this translated into 22 excess deaths per 100,000 population. Next slide. So if we start to think about why we might observe this disparity, there are several possible explanations. Demographic differences between urban and rural areas, different patterns of behavior, different access to insurance. But one important access barrier is travel distance, just the physically greater distance that rural patients have to travel to access clinicians and treatment facilities. Travel distance is increasingly recognized as an important barrier to care. Previous research has found this to be true for obstetric patients and emergency department patients, among others. But travel distance can be particularly burdensome for cancer patients who can face this travel burden over lengthy and complex courses of treatment. Next slide. So to motivate this study, we think about two big questions. Are patients making different treatment decisions based on how far they have to travel for care? Are some patients, for example, choosing to forgo care altogether due to travel distance? And could these treatment decisions help explain observed differences in urban and rural outcomes? Next slide. For this study, we chose to look specifically at travel distance among breast cancer patients. This is because treatment decisions that breast cancer patients face have unique trade-offs with travel distance that we can exploit to answer this question. So women diagnosed with early-stage breast cancer have two treatment options: mastectomy or breast-conserving surgery followed by a course of radiation treatment. These two treatments are considered clinically equivalent and have been for almost 30 years. Mastectomy is a larger and more invasive surgery with a higher likelihood of complications, while breast-conserving surgery is less invasive and has been associated with better cosmetic and psychosocial outcomes. Next slide. However, among patients who elect to undergo breast-conserving surgery, radiation significantly reduces the risk of cancer recurrence and increases survival compared to surgery alone. And without this course of radiation, breast-conserving surgery is no longer considered equivalent to mastectomy. However, we know from previous studies that between 15 and 30% of breast-conserving surgery patients do not complete recommended radiation. And why might this be? Well, a typical course of conventional radiotherapy requires daily travel to radiation facilities. A typical course would be 5 days a week for 5 to 7 weeks at a time. Next slide. So the research aims of this study are first to assess the burden of travel distance to radiation facilities among breast cancer patients who receive radiation. And the second is to evaluate this relationship between travel distance and patient treatment decisions, namely their surgical choice, whether they received a mastectomy or breast-conserving surgery, and second, optimal receipt of radiation among early-stage breast cancer patients. Next slide. The data source we used is the SEER Medicare Cancer Registry linked claims data over a 10-year period from patients diagnosed between 2004 and 2013. Sierra Medicare data covers approximately 28% of the total US Medicare population across 15 states. And importantly, we had access to restricted geographic identifiers that allowed us to calculate our travel distance measures of interest. Next slide. Our patient cohort consisted of women aged 65 and over enrolled in fee-for-service Medicare who were newly diagnosed with stage 1 or 2 breast cancer between 2004 and 2013, who underwent surgery as part of their initial course of treatment. And our sample size was a little over 61,000 women. From the Sierra Medicare data sources, we collected the demographic and disease characteristics you see listed on the slide. Next slide. We developed a claims-based method of identifying radiation treatment facilities, and we define those facilities as facilities billing claims for a delivery of radiation treatment according to the relevant ICD-9 and CBT codes as outlined in this table. Next slide. We used Google Maps to calculate driving distances and driving times, and ArcGIS to identify the nearest available facility for each patient. We calculated both the actual distance patients who received treatment traveled for their treatment, as well as the distance to the nearest available radiation facility for all patients in our cohort, whether they received treatment or not. Next slide. So to give you a visual example, we have patient 1 who was treated at facility A, but who actually lived closer to facility B. For patient 1, we are able to calculate 2 measures of distance: how far they actually traveled to receive the radiation treatment, and how far they would have had to travel had they accessed care at their nearest available facility. For patient 2, who wasn't treated with radiation at any facility, we're still able to identify that they lived closest to facility A and to calculate the distance they would have had to travel to receive care there. Next slide. We also include a measure of whether or not a patient received guideline concordant treatment. And here we define guideline concordant treatment as a patient either receiving a mastectomy or receiving breast conserving surgery plus the follow-up course of recommended radiation. And we define guideline discordant treatment as receiving breast conserving surgery without radiation. Next slide. Each of our treatment decision models were set up as multivariate logistic regression models. We categorize distance to the nearest available treatment facility into distances of less than 10 miles, 10 to 25 miles, 25 to 50 miles, and greater than 50 miles. We also controlled for the patient and tumor characteristics I discussed before and the SEER registry from which the data were obtained. Next slide. We also developed survival models to look at patient outcomes. Using Cox proportional hazard models, we compared 10-year overall and breast cancer specific survival among patients by how far they lived from treatment facilities, as well as whether or not they received guideline concordant treatment. Next slide. So here's a summary table of our results. We found that on average, rural patients traveled about 3 times as far as urban patients, 15 miles versus 41 miles to their radiation treatment, and that their nearest available facility was more than 4 times farther away, 5 miles versus about 22 miles. And it's important to remember here that the distances presented in this table represent one-day, one-way distances. The median patient in our cohort completed 33 days of radiation treatment, meaning that the average rural patient logged nearly 2,700 miles and 55 hours of travel over the course of their treatment. And for those having trouble visualizing just how far that is, next slide. It's about the driving distance from Philadelphia to Los Angeles. Next slide. Now we look at the results of our treatment decision models. And first here we look at the relationship between travel distance and choice of surgical treatment. We find that patients living farther from a radiation facility are more likely to undergo mastectomy rather than breast conserving surgery. Patients living more than 50 miles from a radiation facility had 48% higher odds of receiving a mastectomy compared to patients living within 10 miles of a radiation facility. And this translates into about an 8 percentage point increase in the mastectomy rate. Next slide. Next, we look at the relationship between travel distance and receipt of radiation. And here we find that patients living more than 50 miles from a radiation facility had 72% higher odds of not receiving the recommended follow-up course of radiation compared to those living within 10 miles of a radiation facility. And this translates into about a 7 percentage point decrease in radiation receipts. Next slide. Now I'll move on to the results of our survival analysis. So first I present here the unadjusted Kaplan-Meier survival estimate. And here you can see a significant association between patient travel distance to radiation facilities and overall survival. Patients living farther from radiation facilities experience worse survival at pretty much every time point. Next slide. Now we want to look at the relationship between travel distance and survival, adjusting for the patient and disease characteristics that we controlled for in our treatment decision models. And here we continue to see a significant relationship between distance and survival. Patients living more than 50 miles from a radiation facility continue to have worse survival than those living within 10 miles. Now you'll notice on the top of this slide that I say that these results are partially adjusted. And when I say that, it's because this model leaves out one crucial element of our final Cox model, and that is adjustment for patients' treatment decisions, whether or not they received guideline concordant care. Next slide. And so we see here in our fully adjusted model, once we account for receipt of guideline concordant care, the independent association between travel distance and survival goes away. Next slide. We interpret these results to mean that the role travel distance plays on survival is mediated by this receipt of guideline concordant treatment. Distance to care affects the likelihood that you receive guideline concordant treatment, and receipt of guideline concordant treatment affects your likelihood of survival. In the fully adjusted model, we in fact find that patients who receive guideline discordant care have worse overall in breast cancer specific survival than patients receiving guideline concordant care. Next slide. And importantly, these results hold across all distance categories. Here we restrict our results to just patients living greater than 50 miles from a radiation facility. And we see that among these patients, those who do manage to receive guideline concordant care fare much better than those who do not. Next slide. So to summarize our findings, we find that travel distance to radiation facilities may pose a significant burden for rural breast cancer patients. Travel distance to radiation facilities was associated with both surgical choice and radiation treatment choice, as well as receipt of guideline concordant treatment. Our survival results suggest that it's not the case that rural patients face just innately worse survival. It's the case that these patients are less likely to receive guideline concordant treatment, and it's these treatment decisions that may be resulting in poorer survival outcomes among rural patients. Next slide. So if we think about the policy implications of our results, if we believe that urban survival disparities are in part a result of differential treatment decisions caused by travel distance, we should be able to do something to address them. Policymakers should look for and emphasize solutions that either reduce the burden of travel for patients or improve treatment completion despite travel burden. Such solutions could include transportation and lodging support or reimbursement to patients, adoption of shorter treatment regimens, and expanded use of telemedicine where appropriate. Finally, this research has important implications beyond breast cancer. Again, we chose to focus on breast cancer as our case study because of the travel versus treatment decisions trade-off that were apparent and observable that we could exploit in our analysis. However, our results regarding travel distance and radiation may extend to other cancers that are treated with radiation, such as prostate and thyroid cancer, as well as the use of palliative radiation among cancer patients. Beyond cancer, travel burden may be leading to suboptimal treatment receipt among a number of conditions that require intensive specialist or long-term follow-up care for rural populations. Next slide. So thank you all for listening, and I'm happy to answer any questions.
All right, thank you. So we have a question of clarification about the distance measure. It was calculated as distance in miles as the crow flies and not travel distance?
No, so we actually use Google Maps to calculate the actual driving distance. So it's a distance measured by road networked, the typical course that someone would take if you plugged in the search on Google Maps, kind of the first hit that would come up on Google Maps. It takes that and calculates the travel distance that way.
And another question, were there regional differences in your findings?
So we didn't, it looked pretty much, there were the urban and rural differences, but then when we broke it down by states across the STEER registry, each state is a little unique. Obviously, some states are almost completely urban, some states are much more rural, but kind of the urban-rural patterns were consistent across states that had a large enough rural population that they could be studied separately.
Okay, so there's some discussion going on over in the chat room to just kind of acknowledge that there are other barriers. Some women may need it's not just the travel distance, but they may need a driver, which represents a barrier. There's also sort of the time away from work or the need for childcare. And another question asked about the role of chemotherapy in terms of outcomes. Did you look at that in addition to, and then, so I'm just gonna give you all of these questions.
Okay.
And then sort of how do you think how do you think telehealth will impact your work?
Yeah, so first of all, I definitely think there are a lot of barriers, not just the physical distance, but a lot of things involved in travel for treatment, the taking time off work, the finding someone to drive you if you can't drive yourself, or finding someone to watch your kids if you need to take time away. And I think, you know, living further away from treatment just compounds all of those issues. It makes it harder to find someone who can take it. It's more time you have to take away. And it's harder to ask someone to make that commitment to drive you. In terms of chemotherapy, we didn't look specifically at chemotherapy in this study, but that's certainly something we could look at in future. And what was the other question?
Telehealth.
Yeah, so I think that's really interesting. I think COVID is providing an interesting model for maybe pushing the telehealth conversation forward faster than it would otherwise. But I think there's definitely opportunities, particularly for cancer treatment, for planning visits, for follow-up visits, for counseling visits, maybe not specifically for the delivery of the radiation, but in kind of all those extra appointments that you need to have really compound the travel burden. And so eliminating those or reducing those for patients, I think, can go a long way.
All right. I think that covers the discussion that's been happening. So our final speakers for today are Drs. Helen Parsons and Ann Blaze. Dr. Parsons is Associate Professor in the Division of Health Policy and Management in the School of Public Health, and Dr. Blaze is the Director of Cancer Survivorship Services and Translational Research.
All right, good afternoon. Today we will be discussing a number of projects that we have proposed along with many other members of the Cancer Center and some of our community partners related to rural health and cancer. Next slide, please. Today we will specifically be presenting an overview of 2 projects that have been proposed and discuss opportunities for potential collaborations and expansions of these projects or potential extensions as well. And then after that, outline some additional projects that have been proposed or are currently in the field related to rural health and cancer and discuss some potential opportunities around those as well. Next slide. The first project that I'll be discussing today is focused on advancing rural cancer control research capacity within our Minnesota catchment area. This is more of an infrastructure type project that was proposed, whereas the second project that Dr. Blaze will discuss is more of a more traditional research project. Next slide, please. We know from prior research that rural healthcare providers face a number of different barriers to participating in clinical trials. Previous research has demonstrated that there's limited research infrastructure, particularly within rural areas, that many of providers, not exclusive to rural areas, but particularly in rural areas, that providers may lack formal research training where that could present a barrier to their comfort or interest potentially in participating in clinical trials, as well as a number of competing demands that they have, including providing patient care, and that could potentially present a conflict to participating in clinical trials. Recognizing these barriers, the Cancer Center received an opportunity to reply to a supplement to the Cancer Center grant last year, specifically focused on enhancing access to rural cancer control efforts within our Minnesota catchment area. And as this was proposed and came out as a supplement, we had some initial talks with the Minnesota Cancer Clinical Trials Network, who were in their initial stages of enrolling patients onto clinical trials. And as you heard earlier from our partners, that the Minnesota Cancer Clinical Trials Network provides critical access to rural disadvantaged populations in the Minnesota catchment areas in their access to cancer clinical trials. And what we thought was a great opportunity to help to enhance some of the services and the resources that were originally proposed within the Minnesota Cancer Clinical Trials Network, and expand and enhance the work that they're doing with the addition of the supplement grant that was available. So we proposed a number of different enhancements through this grant initially to help to enhance the capacity of the Minnesota Clinical Trials Network and understand some of the barriers that they were facing. Next slide, please. So as part of this project, we initially proposed a number of different objectives. The first was to understand and address barriers to cancer clinical trial participation, specifically within the rural sites that were participating in the Minnesota Cancer Clinical Trials Network. The second goal of the project was then to characterize the demographics and the healthcare needs of this population to really understand the patients who may be eligible for and were participating in cancer clinical trials within our Minnesota catchment area. And finally, to meaningfully engage with providers to ensure the sustainability both of the providers as well as the key areas of expertise within the network. You can see on the right some of the proposed partner sites that were specifically rural that we had engaged with to initially put together this proposal. And once complete, the goal of the project was to enhance our capacity to provide access to state-of-the-art cancer-controlled research and clinical trials, not only for patients, but for providers and health systems within our rural Minnesota catchment area. Next slide, please. The first aim of the project that we proposed was to first evaluate key barriers and facilitators to participating in cancer clinical trials that were offered within our Minnesota catchment area from not only the health system and the provider perspective, but also the patient perspective, recognizing that there are different barriers and facilitators to participating in trials depending on the partner that we were asking. So to understand these barriers and facilitators, we proposed to conduct first a number of key informant interviews with health system leaders, providers, social workers, and clinical staff, and supplement that with focus groups from cancer survivors themselves who had been treated at each of the participating rural sites or had been interested in participating. The goal in conducting this work was to understand barriers and facilitators to participating in clinical trials and use this information then to prioritize barriers in order to enhance the structure and the resources that are offered not only within the Minnesota Cancer Clinical Trials Network, but also within our Minnesota catchment area more broadly. And finally, to understand opportunities to enhance, engage with patients, providers, and health systems within the network and our catchment area more broadly. Next slide. The second aim we had proposed was to more systematically characterize the population of patients who were engaged with or eligible for participation in cancer clinical trials within our rural Minnesota Cancer Clinical Trials Network sites, specifically characterizing their demographic, cancer, and behavior characteristics. And we propose to do this through some enhanced informatics infrastructure and reporting capabilities. So specifically, it would be to create more of an embedded query and reporting tool within the electronic health record that would allow for us to more easily and consistently identify not only patients who are eligible for cancer clinical trial participation, but also some of their demographics and key behavioral measures. For example, smoking, previous cancer screening behaviors, or other factors. And then we finally proposed to develop these using these developed templates to characterize our population so that we had a more holistic view of the demographics and clinical characteristics of patients who could potentially participate or had participated in trials that could be used for a number of different purposes, including potentially in pilot data for future proposals, engagement with partner sites, and also work with our other clinical and community partners to provide more background information about potential gaps or areas where we could engage with those communities. Next slide. And the final aim that we had proposed was to engage providers and clinical staff at rural sites in more foundational research design and clinical research practice training to help really build their internal capacity for partner-informed collaborative research. So the research was not one-sided, but really more of a collaborative research effort. So the approach to this was to utilize some of the resources that were very high quality and that had been previously created through our CTSI, the Clinical Translational Research Institute, and supplement those with monthly webinars on topics of interest to the partners within each of the MNCCTN sites. And the topics might vary, but would be focused on topics of interest to the partners within each site based on their previous background, their interest, and how they'd like to help to move the network forward. They may include anything related to basic statistics, ethics, clinical research training, and other topics. So while this project was not initially funded, we are continuing to pursue the opportunities to build these resources into not only the network, but also our catchment area more broadly to continue to enhance our capacity for conducting rural cancer control research within our Minnesota catchment area. And I'd be happy to answer any questions later about future potential for collaboration. So with that, I'm going to pass the slides over to Dr. Blaze, and she'll be discussing our second project.
Thanks, Helen. So I'm going to discuss a project that we have applied for funding for, and you may hear a little bit of background noise. We've had some family things go on this afternoon, so hopefully you can hear me clearly and won't hear too much distraction. So this second project we're going to discuss, Steve Johnson and I submitted an application for funding for, and Steve works in health informatics called Precisa, looking at patient-reported cancer immunotherapy symptom alerts. Next slide. So you might ask, what are patient-reported outcomes? So patient-reported outcomes are really a central piece of patient-centered care. They are health outcomes directly reported by the patient who experienced it, as opposed to a nurse or a physician reporting what they think the patient told them. Some studies have collected PROs in the survivorship period and have varying conclusions regarding their usefulness at identifying patient symptoms and concerns. And they are used really to evaluate effectiveness in cancer care and side effects of new cancer drugs. So they've really become a standard of care. And right now, for the most part, they are collected manually when patients come to the clinic. One study I wanted to reference published a couple of years ago by Ethan Bosch at the University of North Carolina. They looked at a study of around 760 individuals with metastatic cancer receiving chemotherapy. Patient-reported outcomes were obtained via a web-based platform. And within this study, they demonstrated that severe toxicities can be identified and interventions can be successfully provided by a nurse. Many of the patients only completed their PRO surveys during their clinic visits, not in between visits. There was no built-in clinical decision support tool. However, what surprised everyone in this patient population with advanced metastatic setting is just by having patient-reported outcomes, there was an improvement in overall survival. The study's secondary outcomes looking at reductions in emergency department visits and hospital admissions only showed a statistically significant reduction in a part of the intervention where patients were inexperienced with using devices. Next slide. Building off of Steve Johnson's initial work, he developed a PRISM mobile application, and this was an AHRQ Step Up App Challenge winner. Within this development of this application, they had patients easily fill out a promise survey, which is a type of PRO survey on their own device. Patients were invited via text message to sign up, to download the application and take the survey. It was done as really a pilot or platform to say, can patients report their patient-reported outcomes via application, and can the answers to this actually be seen within the medical record? This is a multidisciplinary team of researchers, physicians, and software developers that was not done. It was developed here at the University of Minnesota, and then tested within a second system. Next slide. This just shows you the architecture where they integrated with the EHR. This was a smart patient standalone launch sequence platform that actually can be translated into other medical records. The use of structured data capture where patients reported their promise scores or patient-reported outcomes via their application, went into the PRISM server, and then they asked the question in their pilot study whether or not this could actually be visualized in the medical record. They didn't do anything with the interventions. It was really an initial step to say, can this actually be seen? Next slide. This just shows you a little bit of what the app actually looks like. It's easy and quick for patients to use. For example, in the middle line, it says, does your health limit you during this last 2 hours of any kind of physical activity? A score comes up, and it also allows the patients to visualize the score. Next slide. As I was mentioning, the reports then can be graphed out for the patients to see, and it's then uploaded into the medical record where the provider can see them. Next slide. The current status of this is that this has been undergoing pilot testing at MedStar Health in DC, which is a multi-system of about 10 institutions. The PRISM app itself will then be released as open source early this year. And this just shows you sort of the actionable plan. So Steve and I basically took this platform to say, well, gosh, can we actually make this actionable? Can a clinical decision support tool actually see the results of this? And engage the patient on how to manage side effects, for example, in addition to notifying the physician and the nursing team. We called this Precisa, where we submitted a grant application to develop Precisa. And Precisa provides a clinical decision support tool to collect these PROs within the medical record and provides an actionable, usable, and efficient response with a goal of reducing emergency departments and hospitalizations. Our goal within this is to enroll 1,174 patients receiving immunotherapy. It's a randomized clinical trial, and we are partnering with the MNCCTN to conduct this study. Next slide. I wanted to mention a couple of other projects that are going on involving rural cancer health within that many of the people on the call are involved in. The 10,000 family cohort that Heather Nelson and Dan Lasovich have been involved in. Helen Parsons recently submitted a P30 supplement looking at financial toxicity across our catchment area in Minnesota and how cancer care affects financial toxicity within patients and their family. I have recently been collaborating with partners from Health Partners looking at cannabis use across Minnesota. Money for this project has also been submitted, and we should find out in August. Deanna Teo has been looking at HPV vaccination and cancer survivors, hoping to engage actually rural populations as well. And then I wanted to just mention, sort of building off of the last presentation, that we have a small group within our survivorship team that's been really interested in the clinic since COVID started. We've rapidly implemented telehealth. And as part of that, we overnight essentially switched patients to telephone and video visits. We've been running at pretty much full capacity in the cancer center with our cancer care, but doing this pretty much virtually. We recently analyzed some of this data. Concerned actually that we are developing disparities with telehealth, and at least by some of the preliminary data, our aging population, our rural population, and our minorities are much more likely to have a telephone visit as compared to a video visit. We are in the process of doing some initial analyses to look at how will this change over time. Is this just part of the initial getting ready with technology, or is this something that is going to be persistent? That being said, I think the broader question is, if you have a telephone or video visit, will this actually affect outcomes with cancer care? But I think there's a lot of opportunity for collaboration, and I'm excited to see so many people on the call. So if people are interested in engaging in any of these projects, I'm welcome to take questions. Next slide. Thank you.
Oh. All right, thank you all. So I'd like to thank all of our speakers for participating in today's symposium, and thank our attendees for joining us and for a few questions, but please follow up with speakers if you want to follow up with questions individually. So I guess that's, yeah, so we don't have any questions that went unanswered, so we won't be following up with that, but we sure will be sending out a recording of this, and really encourage you to reach out to speakers for ideas for collaborations, and hopefully this symposium will spark some collaborative efforts in the near future. Thank you very much, and enjoy the rest of your afternoon. And thank you, speakers, one more time. And thank you, Lissa, for coordinating everything. Bye.